Then you have the next important entity, metabolic alkalosis. To understand this, you need some talent. What is alkalosis? Metabolic alkalosis. Naturally, there is an acid in our body which is there in our stomach. If there is a profuse vomiting, let us say congenital hypertrophic pyloric stenosis in a baby, when acid is vomited out, that leads to alkalosis. Second, whenever our kidney starts losing H plus into urine, that also leads to metabolic alkalosis. Normally, what prevents H plus from being lost into urine? Who is the one who is responsible? Kidney normally retains H plus, unless under exceptional conditions it wants to lose H plus. Aldosterone is a very dirty fellow. He will go to kidney and say, secrete H plus, we don't want you, get out of the body. All H plus is lost from the body. Any condition that increases the aldosterone levels lead to development of increased secretion of H plus into urine, and that decreases the H plus levels in the body, and that lead to development of metabolic alkalosis. What causes high aldosterone? It can be primary hyperaldosteronism because of an adrenal adenoma which is overproducing, which is called CONS. Second, secondary hyperaldosteronism. Whenever you are dehydrated, when your intravascular volume is low, when the renal plasma flow is low, that stimulates the juxtaglomerular cells to produce excess renin, which will cause excess aldosterone, which will cause excess secretion of H plus into urine, which leads to the development of metabolic alkalosis. That is whole story. How do you treat that kind of metabolic alkalosis due to the secondary hyperaldosteronism due to a contracted intravascular volume? Give saline, normal saline, and expand the plasma volume once more, improve the renal perfusion, and that excess renin production stops. So that is the reason hyperaldosteronism is broadly divided into two groups: saline responsive hyperaldosteronism in the dehydrated people, saline unresponsive hyperaldosteronism due to the adrenal adenoma. And in that scenario, what will you do? We will give spironolactone, which is an aldosterone receptor antagonist in case of conditions which are not saline responsive. But generally, dehydration, hyperaldosteronism is equal to metabolic alkalosis. Okay, doc? So summarize. A patient who is on ventilator, where the ventilatory rate is inadequate and he is hypoventilating, will go into respiratory acidosis. A young female who is hysterical, anxious, hyperventilating, walking into casualty, goes into respiratory alkalosis. A diabetic ketoacidosis patient has got high anion gap metabolic ketoacidosis. Then you have a dehydrated guy or a CON syndrome guy who has got metabolic alkalosis. But only 4 things. Obviously, what are the other things that you will have? Suppose we are having acidosis. How will kidney compensate acidosis? It will excrete excess amount of H plus into urine. That's how kidney will compensate. If there is alkalosis, kidney will try to retain H plus. Similarly, when there is a metabolic acidosis, what will lungs will be doing? Acidosis stimulates respiratory center will cause hyperventilation lead to alkalosis, which will compensate the metabolic acidosis. So as simple as that. Now there is one more concept which we need to be sure. Some of you are going to be nephrologists and intensive care physicians within no time. Urinary anion gap is another concept. Chalo bhai. If you know plasma anion gap, urinary anion gap is no big deal. Mainly, why do we use urinary anion gap? In diagnosis of what do we use urinary anion gap? That is what we are going to talk. Just like plasma, urine also is having cations. Sodium, potassium, mainly ammonia, calcium, magnesium. Chloride, bicarbonate, sulfate, phosphate, organic anions are also there even in the case of the urine. Just like plasma, even in the urine also, urinary unmeasured anions. What are they unmeasured anions? Sulfate, phosphate, organic anions. Minus unmeasured cations, which include mainly ammonia, calcium and magnesium, will be called as urinary anion gap, which is calculated indirectly by measuring urinary sodium plus potassium and subtracting from that the chloride. Agreed? Now doctor. The urinary anion gap will help us to differentiate whether a given situation of acidosis is, normal anion gap metabolic acidosis is because of the GIT or kidney. What is the meaning of it? See, we said normal anion gap metabolic acidosis, which is renal tubular acidosis. Why renal tubular acidosis is called normal anion gap metabolic acidosis? Already we discussed now. Typically in the renal tubular acidosis, what will happen to this equation? There is acidosis in renal tubular acidosis, but in that, in addition to the fall of bicarb, there is a rise of chloride, right? And because of the equal rise of chloride for the amount of fall of bicarbonate, overall anion gap is unaltered in the case of the renal tubular acidosis. Hence renal tubular acidosis is called as hyperchloremic normal anion gap metabolic acidosis. Okay, doc. There is one more situation which can happen where the bicarbonate level can go low, same time chloride level can go high. Can you give me one such situation? Suppose if somebody is having a profuse diarrhea. Diarrhea is different from gastroenteritis, gastritis, you know that. Gastritis means stomach, diarrhea means colon. Right? I know that you all know. Now, colon produces rich bicarb stool. Once it is lost into urine, into the stool in diarrhea, bicarb levels, what happens? They will fall. Right? Same time in a diarrhea person, chloride levels will be high. Because of two reasons. Either because kidney is retaining more chloride, or what is the treatment of diarrhea generally that we give? We give saline. Saline contains chloride, and the chloride can lead to hyperchloremia, which also can lead to a high chloride, low bicarbonate acidosis, which is once more a normal anion gap metabolic acidosis. Now we want to differentiate whether the normal anion gap metabolic acidosis in this patient is because of the renal tubular acidosis or is it because of the gut. You will say, what is a big deal about it, sir? You take the history. If he is losing stool in the diarrhea, there is no big deal. You will get in the history. Do you need to do urinary anion gap in order to calculate and prove the fact? It's easy with history. But let us assume you are a patient of renal tubular acidosis presents with diarrhea. So then you need to differentiate now. Anyway, how do you? But anyway, you need to know that kidney has got a special property. What is that? Whenever there is an acidosis in the body, what will kidney will be doing? It combines in the distal tubule, in the collecting tubule, ammonia plus H plus it will combine, forms NH4 plus ion and secretes into the urine, which will then appear inside the urine. So NH4 plus levels in the urine will be higher when if the kidney is intact, in a case of normal anion gap metabolic acidosis where gut is responsible. Okay? But if the gut is not responsible, if the renal tubular acidosis itself is responsible, then what will happen? If the renal tubular acidosis itself is responsible for normal anion gap metabolic acidosis, then acidosis will be there, but there is no NH4 plus excess inside the urine, because kidney lost its ability to secrete NH4 plus, that's the reason. Agreed? So what will happen in the people? What happens to their urinary anion gap? We said no. Urinary anion gap is unmeasured urinary anions minus unmeasured cations. Your ammonia, NH4 plus in the urine, is it a measurable cation, unmeasurable cation? Is it a measurable anion or an unmeasurable anion? It is an unmeasurable cation, NH4 plus. Hence what happens to the urinary anion gap when unmeasurable cation like ammonia increases? It typically decreases. So a decreased urinary anion gap का मतलब क्या है? Kidney is producing excess NH4 plus into urine in response to acidosis. Hence urinary anion gap will be reduced if the underlying cause is gut. In the gut, okay, in the gut. But if it is the renal tubular acidosis, it won't be affected. It remains the same because kidney lost the ability to secrete NH4 plus. So to differentiate between the two. So another way to remember is a positive urinary anion gap means kidney's distal acidification is impaired, but a negative, that means a reduced urinary anion gap का मतलब gut is the one which is basically responsible. That is the place where we use the urinary anion gap, is what I want to underscore to all of you. So summarize, doctor, what are the causes of high anion gap acidosis? We have lactic acidosis, toxins like ethylene glycol, methanol and salicylates, renal failure, ketoacidosis, which can be due to diabetes, alcohol or starvation, is what you have to be very, very sure about.